Thank you very much. So I'll just move straight into it. This is the organisation that I work for, and we've been delighted to have a number of speakers here during the conference. The overview of the presentation, I'm just going to talk briefly about governance and clinical governance in the context that I'm looking at it. I'm going to give you an analogy, governance approach, some improvement examples as images just talk about. It's that how do we keep checking away at the challenges and the results that we've had, and what are we looking at in the future. The main document that I'm going to speak to in relation to governance is this one, which is available on the website. It's the 2017 Commission document. And just thinking about the very complex organisations and systems that we work within, they tend to have, I suppose, a real conformance approach. And the conformance that's driven is by the internal focus and the external focus. So we have government targets and various other things that we have to meet, and regulatory targets. But governance for me is about leadership, and it's about performance, and it's future orientated. And it's trying to bring together and take us beyond the everyday challenges that we meet and look at more at that broader overarching approach that the organisation might need to take, and the systems. So this is the definition. It's a set of relationships, and it's taken from that Commission document. Relationships and responsibilities established by a health service between state territory departments of health, governing body, executive, clinicians, patients, consumers and stakeholders to ensure good clinical outcomes. It ensures that the community and health service organisations can be confident that the systems are in place to deliver high quality health care and continuously improve, and I really emphasise those last points. And if we think about some of the challenges, like in Victoria with the Bacchus Marsh, Jerry Warra challenges, what wasn't happening there, or what did occur, is that the community has lost confidence in that system. And this is just another way to say that clinical governance is part of the overall corporate governance, and should be, and I believe now more and more is being requested of boards and executive, to fold it into the everyday work and responsibilities that a chief executive and executive team has. These are the various components in the national framework, and if you look at those components, they come through in many of the standards. So in Standard 9, you could pick out each of these within the objectives of the standard. And when I thought further about it, I thought, well, what, for me, governance is about leadership, and I quite like this definition, which is a World Health Organisation definition. And it really is about painting the picture and the vision of what can be achieved, communicating to each others, and then involving and driving and really leading the strategies for realising that vision. But being able to motivate people, absolutely get the executive on board, for example, negotiating for resources and supporting everybody to achieve the goals. And there's an enormous amount in that. So just an example about really incremental change, not radical reform. And if you think what came to mind for me, and this is data that's straight off the Victorian TAC site, which is an amazing website for data. Vehicle accidents in Victoria. When I was a kid, 1,000 people used to die on the road per year. So up there, 1,063 people in 1970. And over the sort of the 47 years, there's been many, many, many things. It's now, you're a bloody idiot if you drink and drive. You wouldn't dream of your kids getting in the car without a seatbelt on, etc., etc. And so what's occurred is we're now down to 258 deaths. And that's not been radical reform, it's been incremental change. So, which is pretty amazing given the volume of cars that we now have on the road, and a real tribute to those strategies. So thinking about patient deterioration, this is again about that incremental change and prevention, and really moving from this old paradigm of a very high mortality rate to the Met call. But we still have, as has been said today, we still have a problem with that. We still have death rates from if people get to a Met call. So, and we also have the big demand on ICU or crisis management intervention. We really want to move it back to the point where we recognise abdominal vital signs and again, as been said, actually risk stratify the patients and intervene earlier. So from the point of view, the strategy is really around not getting to this point here. So the intent and the theory of the governance group that we run, called the Deteriorating Patient Committee at Austin Health, is that firstly, if we improve the recognition response using medical emergency calls, we'll reduce cardiac arrest. But really we want to move prior to that. I won't dwell on these, but these are the various elements that are required of us as a governance committee to oversee on behalf of the hospital in that clinical governance. Now, it's a very complex set of standards. Just end-of-life care itself is an enormous amount. Mental state deterioration, let alone physiology, and the recognition response component. That's not all of our committee there, but it's a large portion of it. We have 2 consumers and we have representatives from a range of clinical aspects and all the different sites. But the way that we've approached it is to really break up the work. We have leaders in each of these groups, and the actual steering committee is really more the sort of, I suppose, peak decision-making body, and these different groups will bring various things to us. So this has taken a number of years to develop, but it does work very well for the volume of work that we have. And then, as has just been also said, it's really important that you understand where do you plug into the system from a governance sense. So this is looking at all of the committees. There are different levels of committee, and the deteriorating and the patient committee and the standards is down the bottom there. But the key thing is that I'm able to go to the executive and talk to them about, we've got a really big issue with medical cover on our rehabilitation site, and that we have processes to raise those issues and influence change, which is what we've been able to do. So from my point of view, that governance is like that umbrella across the organisation, and it leads to systems thinking. And 2 principles that I use in my mind, which come from the IHI in the US, which are, let's make our problems visible and let's help people do the right thing. Let's provide them with the tools. If they're pointing out issues, let's work through in a systematic way. So systems thinking enables that delegation. It enables those org-wide responsibilities, education requirements and data collection. This is the escalation policy that we use. This is that interpreted in a flow chart with that 3-tier response. And that's really our Bible from the point of view of the organisation. Just giving a few examples of and many of you will know this in relation to the charts in particular, but to illustrate, this is the old style chart. All these charts are portraying exactly the same patient circumstances. In a human factor sense, this one is showing more of a timeline trend, but this is the one that actually demonstrates that for a nurse, whether they're a brand new nurse or doctor, when you move into the purple zone, you've got a problem. Whereas the chart on your left does not readily indicate to me that I've got a patient who's deteriorating. So again, this is helping people to do the right thing by giving them the symbolic indicators. Another thing from the point of view of that systematic approach, we've had this problem with rogue calling criteria where we found that there are what appears to be, and this needs more analysis and discussion, but it appears to be where people are extremely altering the calling criteria. And is that about avoiding the calls? Is it with perhaps not with the best understanding of the physiological changes occurring in the patient? So what we've just done is implemented upper and lower limits, calling criteria, and we're actually going to hard code these into Cerner, which is something that we're working through at the moment. I have no doubt that this is going to cause a bit of controversy, and we're going to have some discussions about, for example, I'm thinking about a 14-year-old patient who was admitted with eating disorders, and he had a heart rate of 28 at one stage during the night. But what occurred was that the escalation policy wasn't implemented. The altered calling criteria were altered, and there wasn't a discussion or a sort of a review of that patient, and so there's now a position in place for that group of patients should they have those sorts of variations. Again, systematically from patient care escalated, undertaking audits of the organisation and looking at what is occurring in this space. So we have approximately 4 calls. Many are not for clinical reasons, but we have had some genuine deteriorations that have been had interventions due to a call like this. What we found was that only 30% of patients actually knew of this term PACE, so we're going to have a more improved approach to promoting it. But it was good to hear that people knew how to get help and they understood the concept of what a patient and carer escalation was. I'd like to just talk now about really the value of data and how we use data. And I find this slide quite compelling, and it's from 2011 where a mathematician put forward to at Davos at the World Economic Forum, and that from the beginning of time until 2000 we used 5 exabytes of data, but now we're going to be generating that every 10 minutes. So it's quite overwhelming, the volume of data is out there, and really part of our role in a governance sense is to package that data up and present it to people in a way that is digestible, usable, can have meaning and stimulate them to think about ways to solve problems. From the point of view of every MET call that we have, the medical emergency team is responsible for inserting the call into our Riskman system, and that gets put in real time, and there's an email that goes to the relevant people. So this demonstrates to us, you can see here number of MET calls is the blue line. The brown line down the bottom is the number of multiple MET calls. Then we can see it by specialty, the reason and the location. And you can click on all of those bars and it actually reconstitutes what the chart tells you. You can click on orthopaedic surgery and it will refashion that information just for orthopaedic surgery. So data being the new oil from our point of view, that's an important part of us having insight into what is occurring across the hospital when we have approximately 300 calls per month. From the point of end-of-life care, as has just been spoken, this is a really big challenge, and so we had the subcommittee, they developed a good death model, and they had a number of years ago they trialled intervening through a palliative care fellow, attending MET calls, attending the MDM for the Gen Med unit. And it was interesting to see, again, the use of data, that they had a reduction in medical emergency calls because of that palliative care intervention. Again, it's a resource. We weren't able to continue that resource. We've now made a case using a paper that's just been published by Ireland in Australia, demonstrating that an intervention early on with PAL care input and engagement can reduce the expenditure on patients prior to their end of life. So we've put forward under the heading of choosing wisely end of life care, or what we're calling clear decisions, and we're going to start a new project in November looking at that. This is some other data where we invite units to come and speak to us about how do they use that medical emergency data. So the anaesthesia department, they actually got different cuts of the data in relation to time between post-operative period and when the MET call occurred, and this was the time post-surgery to a medical emergency call. They've then broken that down and put, according to the ASA grade, the reason for the call, MET calls with hypertension and the types of airway management for the patients. And they're now going to have a look at temperature, anaesthetic, etc., and looking at a research project in the coming year. The next plan that we've got utilising that data is that we're about to launch this probably in the next week, is that we're going to have a report where the wards will be able to insert, say if it's 6 o'clock in the morning or 7 o'clock in the morning, they can put in yesterday's date to today, and they can receive a report, which will say that how many patients in that last 24-hour period have had have breached UCR, not that it's been called, UCR being an urgent clinical review, so the second tier. How many patients have breached MET criteria? How many of those patients that had a MET had had a UCR in 6 hours prior to the MET? How many people have had a multiple breach in that time? And how many have had their alter calling criteria expire for more than 24 hours? So we're calling this rounding with intent. It's not quite real time, it's the last 24 hours, but if the unit has just arrived to do their round, they can get a report for that unit and say, these are the patients we're going to go around on first. They can actually drill down into that report and get the patient names. Furthermore, where it says action rate, and it's 100% there, this is just a sample, I don't expect that we're going to get 100% action rate. We want to use this as an improvement process because a lot of the things that occur get put into the medical record and it takes a lot of manual work to pull it out. We're hoping that this will give people more information. So if that action rate said 50%, that there has been a breach of MET criteria for 2 patients and there was no action rate, that means that none of the things in this lower section of the slide have occurred. And so what we want to do is get people saying, well, come on, we've got to be either actioning this or at least populating the medical record, the electronic medical record, to help us understand what we are and aren't doing. So we're going to use that as an improvement approach as well. So to sum up from the point of view of where are we right now, thinking about that original aim of reducing cardiac arrests, the Austrian rate per 1,000 admissions was 3.2. The US published rate was 2.85 in 2015. Austin's currently sitting at 0.6. You can see there we sort of waffle up and down, but we are at that point, and we now really have a very good case understanding of the actual cardio-respiratory arrests. But it is the extreme end of the scale, and really it's more about the initial deterioration. So the sorts of things, and I attribute this slide to Daryl Jones, and we're sort of thinking about this at the moment, is where the risks are for us now and the areas that we want to spend time are around goals of care and end-of-life care, the perioperative medicine process in preparation of the patient for surgery or any sort of procedural work, the sternal vital signs and that report that I just showed you, urgent clinical review, we've got work to do there, responses by parent unit, the ability to have access to critical care, the oversight of a MET leader through the team, and then the multiple emergencies and having attendance there. Under education and training, there's the training of HMOs and interns to manage and recognise deteriorating patients, and then the leadership and governance from the point of view of this rounding with intent and having a ready dashboard. I love to see that report up on an electronic dashboard ready for at any time. So always lots of work to do. But I guess I leave you with the challenge, just thinking back on that road toll and that 47 years it took, setting up very strong governance structures and the leadership needed, make your problems visible, be discussing them all the time, help people to do the right thing, providing them with the tools and the direction and the leadership, and aiming for incremental improvements rather than radical reform. You will fail. It's, for the rule in the IHI is fail fast and fail often. If you accept failure and make yourself vulnerable, it's really good because it gives you permission to go, well, we gave that a shot, it didn't work, we're just going to keep going at it. Thank you very much.